Okay, good day. We're going to discuss and speak about neurological disorders. And we will start with syncope. What are the possible causes of loss of consciousness or syncope? We have the vasovagal syncope, which is a simple faint, and we have been discussed that in the cardiovascular lecture. It is due to stimulation of the parasympathetic system provided by the vagus nerve due to any situation of severe fear or severe stress or the view of unpleasant situation where there is reflex stimulation of the parasympathetic system through the vagus nerve, leading to bradycardia, decreased blood pressure, and this can lead to loss of consciousness or simple faint. Situational syncope, we have discussed that also under the name of respiratory syncope, where there is loss of consciousness due to any cause of increased abdominal pressure, which decreases the venous return. This decreases the cardiac output and decreases the amount of blood reaching the brain. This can occur with cough, a bout of continuous cough, or during micturition if there is urinary obstruction. This can lead to loss of consciousness. And we have the carotid sinus syndrome or carotid sinus hypersensitivity. We discussed this also in the cardiovascular system, where any gentle pressure on the carotid sinus in the neck can lead to the stimulation of the vagus and the parasympathetic system, leading to hypotension, bradycardia, and maybe loss of consciousness. Third cause is epilepsy. At the beginning of the epileptic attack, the patient loses consciousness, and then this is followed by the seizures or the convulsions. Transient ischemic attack, which is due to a stroke, which may be due to thrombotic event in the brain, thrombosis, which can lead to loss of consciousness plus some defects, neurological defects like hemiparesis or hemiplegia, but this resolves in less than 24 hours. This is the transient ischemic attack. Postural hypotension. Postural hypotension, we've discussed this. It can occur in old age due to weak reflexes, where the normal reflex, which is when you suddenly stand up from the sitting or the lying down position, usually there is initiation of vasoconstriction in the blood vessels of the lower limbs, which limits the pooling down of blood to the lower limbs. But in old age with weak reflexes, and also in hypertensive patients who are taking the antihypertensive drugs, we get pooling of the blood to the lower half of the body in the wide dilated blood vessels. This reduces the cardiac output, leads to hypotension and maybe loss of consciousness. Drop attacks. This is due to sudden weakness of the legs, and usually it resolves spontaneously. Stokes-Adams attacks are due to arrhythmia, cardiac arrhythmias. Anxiety in itself can lead to loss of consciousness or syncope. The Meniere's disease, this is a disease of the inner ear where there's vertigo, tinnitus, and maybe deafness, hearing loss. And finally, choking. Choking can lead also to loss of consciousness due to suffocation or decreased oxygen in the blood, and which leads to decreased oxygen reaching the brain. So we have the vasovagal syncope, we have the situational syncope, epilepsy, hypoglycemia. Hypoglycemia, yes, when the blood sugar drops in the blood, this can lead to loss of consciousness. Transient ischemic attack, postural hypotension, drop attacks, Stokes-Adams attacks, anxiety, Meniere's disease, and choking. Epilepsy. Epilepsy, we have two classes of epilepsy. The one with fits or with convulsions are the grand mal attacks or the grand mal epilepsy. And we have second class, which is the petit mal, or the blank stare, where there's a blank stare like this picture of this child, where the patient or the child stares at the ceiling for a few minutes and remains like this until it resolves spontaneously. This is a sort of epilepsy. It's called petit mal epilepsy, and is treated like the grand mal epilepsy with anti-epileptic treatment. During a fit or a convulsion in grand mal epilepsy, there's altered breathing. The breathing stops, and there's cyanosis, sometimes tongue biting, and this is diagnostic that this is not pretending or is not malingering. There's urine incontinence and sleep for more than 12 hours after the fit. If the fit continues for more than 5 minutes, then we have status epilepticus, and this is an emergency and requires urgent treatment by benzodiazepine or diazepam intravenously. What are the dental considerations? Ensure that the patient is regularly taking his medication, because this makes wide spacing of the epileptic attacks and reduces the risk of having an attack during dental treatment. In general anesthesia, avoid the epileptogenic agents like methotrexate or enflurane. IV sedation is very useful, and oxygen by nasal cannula is also useful. Stroke, cerebrovascular accident or CVA. Contributing factors may be hypertension and also atherosclerosis. The etiology may be hemorrhagic, like subarachnoid cerebral hemorrhage, thrombotic, which is the most common type of stroke, or embolic from cardiac emboli in atrial fibrillation or after a myocardial infarction. In the hemorrhagic type of stroke, the contributing factors are hypertension, while in the thrombotic and the embolic strokes, the contributing factors are atherosclerosis. The results of a CVA: there is sudden loss of consciousness, there is a hemiplegia or weakness on the opposite side of the cerebral lesion, or sometimes it's only heaviness or weakness. We call it hemiparesis. There may be loss or slurred speech. Speech may be lost or slurred speech when the cerebrovascular accident affects the speech center. Transient ischemic attack. Transient ischemic attack is a CVA that resolves in less than 24 hours, and these patients are treated with lifelong aspirin. This is the etiology. It can be hemorrhagic, it can be thrombotic, or it can be embolic stroke, where there's an embolus, thrombus in the heart that detaches and goes through the circulation up to the brain, where it lodges and obstructs a small blood vessel. This is a thromboembolism. Dental management in cerebrovascular accidents. We have to defer treatment until the condition is optimized, take a good history, because stroke patients may be taking for treatment anticoagulants, or they may be hypertensive, and this hypertension needs to be controlled. With local anesthesia, we have to take very good care. There may be loss of reflexes as a complication of cerebrovascular accidents, like loss of the gag reflex or the swallowing reflex. With general anesthesia, we have to strictly protect the airway for fear of any inhalation or foreign body inhalation. In transient ischemic attack, the patients are on aspirin, and we have to take precautions because aspirin is an antiplatelet agent. In Bell's palsy. Bell's palsy is idiopathic unilateral facial palsy of rapid onset. The weakness worsens over 1 or 2 days. Paralysis is of the lower motor neuron type, and all facial muscles are affected on that side. From the eye muscles, the oral cavity, the orbicularis oris muscles, all these are paralyzed. And the Bell's sign, the ipsilateral eye moves upwards on closure of the eye in Bell's palsy. What is the treatment? Treatment is usually by corticosteroids, especially early prednisolone for 5 days to reduce the neuronal edema, and eye patch is used to protect the cornea. In contrast, the upper motor neuron lesion, like in stroke, the forehead is spared. The muscles of the eyes are spared. The patient can close his eyes. There's the orbicularis oculi muscles are not affected because there is bilateral nervous supply of the upper part of the face. And this is the Bell sign, where the ipsilateral, which is the eye on the same side of the lesion, moves up on closure of the eyes. This is a sign of Bell's palsy. Thank you very much.